This section, we are going to focus on caring for clients that have genitourinary conditions with a focus on obstructive conditions as well as men's health conditions. When we look at the obstructive disorders, we're going to look at urolithiasis, we're going to take a look at kidney stones, we're going to talk about BPH, we're going to look at prostate cancer, as well as talk about some urinary diversions. The men's health side of things, we'll continue our discussion of BPH. We'll talk about erectile dysfunction and some testicular disorders and cancers. You're going to be exploring the sexually transmitted diseases and infections when you are in your maternal child section of Block 3. What I want you to focus on is how do you care for these patients? If your patient is experiencing this condition, how are you going to provide care for them? What are you going to do before the condition occurs? What are you going to do afterwards to help them with recovery? I want you to think about labs and diagnostics that would be relevant. If you're making that S-bar phone call to the healthcare provider, what are some labs you might request? What are the biggest assessments to focus on to show you if your patient is getting better or if your patient is getting worse or having some complications? So again, keep the nursing perspective in mind. When we talk about obstructions, you can see that obstructions can really occur throughout the entire urinary tract. We can get stones that occur in the pelvis of the kidney themselves. You can also find stones that get caught throughout the ureter. We can even have strictures that occur in the ureter, which is that kind of narrowing area or tightening in that ureter. We can also have stones that occur in the bladder. You can have tumors. Tumors can cause an obstruction. You can have obstructions that occur that are neurogenic in nature. So we have changes in the innervation of the bladder, so we can't empty the bladder as well. We can also have structures that are kind of outside of the urinary tract that can cause complications with the urinary tract. So a common one is prostate problems. So if your patient has enlargement of the prostate, they have hyperplasia, they have hypertrophy, that's going to put pressure on the urethra, which causes compression and is going to obstruct the outflow of urine. So let's start our discussion with urinary tract calculi, so urolithiasis, or if they're in the kidneys, nephrolithiasis. Now, whenever we talk about stones, kidney stones, I really want you to think of pain. That is the most significant and most prominent assessment finding that you will see in your patient. The body can make a variety of different types of stones. They're going to all look a little bit different, different shapes, different sizes. They're going to be made up of different things, so different precipitates in them or particulates or molecules, depending upon what we're actually forming. The majority of them certainly are calcium, but that's not the only thing that forms a stone. So you want to make sure that you have an understanding that it's really important that we know what the stone is made of for future prevention. So that leads us to the nursing care element of needing to make sure that we know what type of stone the patient has. Means I have to collect the stone, which means that I need to strain my patient's urine. So again, thinking about the physiology, the pathophysiology is going to help you understand why you're doing some of your nursing interventions. The dietary changes that are going to be made based on your patient's history of kidney stones are really linked to the particular type of kidney stone that they have. When we talk about kidney stone disease or urinary tract stone disease, it's much more common in men than it is in women. Usually we see a greater incidence of this in our summer months, and that's because of dehydration. Although just living in Arizona alone is enough to put you at risk, male or female, for a kidney stone. And that's because we're having an increased amount of insensible fluid losses through sweat. We're not as good about replacing fluid in our body with water. If we're drinking tons of soda, tons of coffee, that's not really helping us out because those are both acting as kind of a diuretic, so we're not really getting the benefit of the fluid from those. Somebody who takes in a lot of dietary protein, that is also going to put them at risk for the development of kidney stones. Somebody who's had kidney stones in the past, they are much more risk of getting a kidney stone again. They kind of occur cyclically every 5 to 7 years. So we really want to make sure that we capture them at the end when they've passed the stone before they're going home, that we really have educated this patient on how to prevent them from occurring again. And a lot of that is related to hydration and dietary changes. There is some evidence to support that there is some genetic link to it as well. So if you have a family history of kidney stones, you're also more likely to develop kidney stones. People that are in a very sedentary lifestyle, if they're immobile or maybe their job just requires a lot of sitting, they're at increased risk for kidney stones as well, because our bones, if we're not using our bones, then we are going to go into bone resorption. Bone resorption means that we're going to be pushing a lot of calcium out into the bloodstream. That calcium goes to the kidneys, it precipitates out, and it forms that stone. Again, when you think calculi, I want you to think pain. The pain is severe. It'll be back pain, it'll be flank pain along that costovertebral angle. Usually it's going to radiate all the way down into the groin. The pain is usually people say is the worst pain they've ever experienced in their life. It usually comes on very, very quickly. All of a sudden, they're just in such excruciating pain, they go right to the ED. And the reason that they're feeling this pain is because the stone is actually moving its way down the ureter, and as it moves down, it scrapes and pulls all along the way. And sometimes when they eventually pass the stone and it's the size of a grain of sand, they think, oh, why would that little thing cause so much pain? But it really does. I mean, it is absolutely excruciating. And it's because my ureter is so tiny, and putting this stone, this precipitate out, trying to move that through, it really just pulls and stretches that ureter and damages as it goes all the way down. And it's trying to make room for it. Your ureter does dilate a little bit to try and make room for that, but it's still quite painful. Your patient will start vomiting. The pain is so much. Sometimes they even pass out. They get very diaphoretic. So we really have to identify, is this a stone they're going to be able to pass or not? Many times they'll make the diagnosis just based off of symptoms. They don't really need the diagnostics to tell them that they have the kidney stone, but we use these to tell us where the stone is located and does this look like it's going to be something that can be passed through the urinary tract or not. A CT scan is pretty common, tells us kind of where the stone is located. They can do a UA. Usually see some blood in the urine. That's just because that stone has been pulling its way through that urinary tract and causing damage, causing bleeding. And then afterwards, the biggest diagnostic test that is done afterwards is when we strained the urine, we captured the stone. That stone needs to be sent out for analysis so we know what it's made up of. That really helps us with our teaching later on. So as you look at our collaborative care, top priority is going to be pain control. We have got to control the patient's pain. They are going to be in just agonizing, excruciating pain. We can't really eliminate the pain, but we can try and get it under control so it's a little bit more manageable for them so that they can be mobilized. We've got to hydrate them, really force fluids, get lots and lots of fluids into their system, because we need to make sure the kidneys are being filled up with fluid so they're filtering it out. We're creating a nice good propulsion of urine, being able to move and propel that stone down through the urinary tract into the bladder and out through the urethra. If we need to, we can do some pharmacologic interventions. We'll sometimes see that they'll use alpha adrenergic blockers. Those actually are going to relax the smooth muscle in that ureter. And by relaxing that smooth muscle, it makes it a little bit easier for that stone to pass. Most of our stones can pass without having to do any type of intervention, but some of our stones, if they're larger and they can't get through, now we're going to have to do some type of endourologic procedure. A really important part of your role, in addition to pain control, is making sure that my patient still has urine output. Because if urine output stops, that means that urinary function has changed in some way, usually due to obstruction from the stone. And now that I have full obstruction, now we know, okay, we've got to talk with the healthcare provider. We must have some type of endourologic procedure because it is stuck and it is blocking things. And as it's blocking that urine outflow, the kidney's not stopping making urine. It's still making it, but it can't get out. So that backs all the way up to the kidneys and can cause kidney complications as well. So this is where things like lithotripsy come into play. Sometimes they'll use a scope, so they can get a scope up in there and take a look at the urethra, the bladder, the ureters, try and see where the stone is located, what the size of the stone is. They can also, if they can get all the way up, they can get into the nephrons, take a look at the kidneys there. And that gives them a little bit more information to decide what is going to be the best way to treat this. If the stone is large and they're not able to pass it on their own, or if it's stuck in the pelvis of the kidney, we know that that's going to be too big usually to get through the ureters, then they'll need to undergo a procedure that's going to break up the bone. So the most common procedure to break up that stone is going to be lithotripsy. So lithotripsy is extracorporeal, which means that it is something that's going outside the body, and we kind of place these two beams that kind of are going to send waves that are going to pulsate basically that stone. And as they pulsate that stone, it starts to shatter that stone. It breaks into a bunch of tiny fragments. Usually your patient will be sedated through this procedure. Now, if that didn't work to break up the stone, so we're not able to see if it does work, you'll see that kind of bunch of sand kind of grains that just come pouring out. But if that doesn't work to break up the stone, then what they'll have to do is switch to something else. So maybe a percutaneous removal of the stone. So this is where they're going to take a probe and they put it actually directly into the renal pelvis. And that is going to help them be able to pull out or remove those stones, or if they need to, they can break them up into even smaller pieces. But this procedure is much greater risk than some of my other ones because now I can add additional trauma to the kidney, which could be one of those events that could lead to renal failure. Again, we'll talk about renal failure in another section. Also, this is increasing the risk of infection because I'm putting something right into the kidney. If I absolutely have to, they can undergo a surgical removal, although that's not the first choice by any means. If your patient did go through the lithotripsy procedure, a part of your role as a nurse is post-care. So after they've had lithotripsy, you may notice that they still have some kind of colicky pain, so meaning it comes and goes in the flank region. We might notice that there is blood in the urine. That's actually quite common post-lithotripsy. Sometimes you'll see that the patient is put on antibiotics for a short period of time just to try and reduce the risk of infection. And we want to make sure that we're talking with the patient about what their urine is going to look like. We still want to strain that urine because we broke it into all these little pieces. And so you basically just have sand that you're kind of filtering through those traps. If there was a complete obstruction of the ureter, they may need to have a nephrostomy tube. And a nephrostomy tube is going to be a catheter, but it is inserted into the kidneys. So we're going right into the pelvis of the kidney. It's going to come out and attach to this tube that goes outside, and it's into a closed drainage system. You need to make sure that there are never any clamps that are placed on that. There's no kinks in that tubing. That always needs to be freely flowing. That's really important. Occasionally they will order irrigation of the tube, and if that is needed, you're going to use an absolute maximum of 5 ml. It's going to be a sterile procedure, and you're going to do sterile saline. And usually if that is required, the healthcare provider will be involved in that procedure. So once they have passed the stone, they're in the recovery phase, they're ready to go home. We're going to engage in dietary teaching. This is a great time to capture their interest because they never want to go through that level of pain ever again in their life. So they're really open to learning at this point of how they can kind of prevent it from happening again. So for all of our patients, unless it's contraindicated, we're going to tell them to increase their fluids. Lots and lots and lots of fluids. 10 to 12 glasses of fluid a day. And you and I may drink that naturally just being in Arizona, so we need twice that amount. So really thinking about where they're at and what their baseline fluid intake is, think about doubling that. And then we have to look at whatever type of stone it is, that we're going to have some specific teaching based on that type of stone. So if it's a calcium or oxalate stone, we're going to talk with them about decreasing dairy products. We don't want them to have things like nuts or cola, chocolate in large amounts. And they certainly want to avoid antacids as much as possible. A uric acid stone, we want to avoid all those excess proteins. So my meats and veggies that have purine in it, we want them to avoid that, as well as your beers and your wines. And the struvite stone, those are usually come from kind of a slightly different cause. So when they're on antibiotics, they need to make sure they take a full antibiotic regimen and make sure they're flushing their system with water while they're on those antibiotics. And if the stone is a cystine stone, then we want them to really limit their amount of fish intake. Next, we're going to take a look at benign and malignant urinary tract growths. This is a good time to go back to your first med-surg course in Block 2 and revisit the content on cancer. I'm not going to go back through oncology patients here because you've already had that content, so the expectation is you've retained that information. But what we're going to do here is we're going to focus in specifically on some growths that are going to be new to you and how we would care for a patient that have these other conditions. Benign prostatic hyperplasia or hypertrophy is a common condition in the urinary tract that we see in our male adult patients, particularly our older adult patients, and it causes a lot of urologic problems. So BPH is an enlargement of the prostate gland, and this occurs just normally naturally as a result of hormonal changes as men age. So we really see this in our older adult males quite a bit. They're going to have this enlarged prostate gland. Now, because we've got an enlarged prostate gland, you can see here with my normal prostate size, I'm able to have urine flow pretty well. But here, when I've got my enlarged prostate, so I've got BPH, we are pressing down on that urethra and we're not really able to empty the bladder as effectively. So some of these patients will really have a very difficult time emptying their bladder fully. Your patients can have a range of symptoms. They can be anywhere from mild all the way up to severe. Usually the ones that we hear the most with the patients are related to frequency, urgency, dribbling. So basically they feel like they always have to go to the bathroom, and when they have to go, they have got to get there. And then they get there and they're not able to have a stream. It just kind of dribbles, comes out in little bits here and there. And so now they start to have retention in their bladder as well, which can cause a whole host of complications. So they can get a urinary tract infection, they can get stone formation from stasis, and then all of that backup can cause damage to the kidneys and eventually lead to renal failure. There is usually a combination of diagnostic testing that is used to make the diagnosis. They will do a digital rectal exam, and the healthcare provider will be able to feel that the prostate itself has been enlarged. And this is an important part of just general health care for our older adult and middle-aged men. Sometimes they'll use symptoms as well. They may do a UA. Oftentimes the UA shows signs of recurrent urinary tract infections. There may be some red cells in there because we've got this excess growth of that tissue. And it starts to put pressure, which causes some bleeding, and that's where those red cells come from. And then they'll do a test known as the PSA, your prostate-specific antigen. The PSA is a serum test, so it's a blood test that's being done. And they're using this to determine whether cancer might be present within the prostate gland. So even with BPH, we can see a rise in the PSA level. So rather than just looking at one value, what we're looking for is trends in this value. So we would see that there would be a significant increase over time in that PSA level to be more indicative of cancer. There are some medications that we can use, such as your 5-alpha reductase inhibitors, your alpha adrenergic receptor blockers. Those are going to be used to reduce the size of the prostate gland and also prevent additional growth of that tissue. Some patients will need a surgical procedure. The surgical procedure is known as a transurethral resection of the prostate, or a TURP procedure. And we are going to explore this procedure in a little bit more detail when you are in our lab, when we practice with continuous bladder irrigation. Basically, they are going up through the urethra, so it's transurethral, and then they go through and they kind of take out the big pieces of the prostate. So kind of those extra pieces of tissue, those large pieces, they start pulling those out. And then they'll put a catheter in. A really large catheter will be placed, and usually they overinflate, or they fully inflate, I should say, the balloon, and they create a lot of tension at the end of this procedure so that as they pull that downward, it actually helps to kind of control some of the bleeding. And then they will put them on continuous bladder irrigation after the surgery. And it's important that they have CBI, the continuous bladder irrigation, because we need to make sure that the urethra itself remains patent. We don't want any blood clots getting in there and blocking that off, because now we have another type of obstruction. We have a variety of different options in terms of catheters and urinary diversions that you might see. So you're pretty familiar already with an indwelling catheter, one that stays in for a time, straight cath, which could be intermittent, your condom cath, or your pure wit cath, which is the external. And we're going to talk about, again in lab, how to do some continuous bladder irrigation with those catheters. They can place a suprapubic catheter, which is where they go externally through the pubic area into the bladder, so it directly goes into the bladder and then comes out and drains into a Foley bag. They can place nephrostomy tubes. Nephrostomy tubes are going to go in percutaneously, so through the skin, then into the nephron, into the pelvis of the kidney, and then they will drain the urine from there. And again, as those tubes come outward, this is pretty painful for our patients that have these nephrostomy tubes, and it's really, really critical that they are always draining. We always want to make sure they're draining. No kinks, no clamps, nothing should be on those tubes. So regardless of what type of catheter or urinary diversion that you're using, you want to make sure that we're maintaining the principles of asepsis. We don't want them to get a CAUTI. You want to make sure that it is patent, no kinks. You don't want to leave it just sitting flat on the bed above the bladder, because now we're going to have that backflow of urine again. Make sure that you do have urine output, so always checking to make sure that there's good output. Monitoring your patient for signs and symptoms of an infection. Do they have some white cells that are going up? When we look at the urine, do they have white cells in the urine? What does the urine look like? Is it clear? Is it cloudy? What's my patient temperature? Looking at just all of those basic assessment findings that we've already talked about for an infection. And then, because most of these devices are uncomfortable for the patient, is looking at what can we do to make the patient more comfortable overall while they have to have these devices in place. This is a series of images here that just give you a little bit more information about CBI, or continuous bladder irrigation. So you can see that the catheter looks somewhat similar to the ones that you're familiar with, but it actually has 3 ports in it. So we have the port where the urine is going to be drained from. We have the port that goes in that allows us to inflate that balloon. And then we have the port where we're going to be doing our irrigation setup. We have to plan in advance, because when they place this tube, they have to choose this tube if we want to do a CBI. We can't just take a regular Foley and do it. It needs to have each of these 3 lumens or tubes present there. Oftentimes your patient will go for that TURP procedure. Sometimes they're removing a tumor in the bladder, and there's a lot of bleeding. The urinary system is a very vascular system. So we really need to try and control the bleeding and make sure that we're monitoring their urine output. So what we'll do is we'll connect up an irrigation bag to the port, or to the tube on the catheter for irrigation. And we're going to use an irrigation solution. It looks a lot like an IV bag, but it's really, really big. So you'll see this when we get in the lab. It's a big 3-liter bag, and we're running it to gravity. So it's going to run down. And what we want to do is we want to control the speed with which that fluid is moving through for the irrigation. And we're determining the speed based on how many clots the patient has and how much blood that we're starting to see being drained from the bladder. So when I take a look at the output, so the urine output that's coming out, I want to assess the color. So what color is it? If it's slightly pink, that's okay. But if the patient's bleeding, that means that there are areas in the bladder where blood is accumulating and clots are really starting to form. And so that means that I don't have enough irrigation going through the bladder, so I need to turn it up. I don't want clots to form. I really want to prevent that from happening. So if I see clots are forming, or I'm starting to see that there are kind of streaks going through the urine, these bloody red streaks going through it, then I need to turn up the flow. It needs to go much faster. And there's not a rate per se that you're using. You're not calculating drops per minute or anything. You're just going to run it until you aren't seeing kind of those red streaks or that bleeding. We really want to try and prevent those clots from forming. But you have to pay really close attention to this bag because it can empty quickly, even though it's a really big bag. So pay close attention and make sure that you are emptying that Foley bag. That Foley bag can just be bulging with urine plus the outflow. So you have to pay close attention to the bag, both what's infusing as well as what is coming out. Obviously, our goal is to run it as slow as we can to keep a good urine color, but we do have to speed it up if we're starting to see bleeding and blood present and clots present in the urine. When you calculate your output, you really have to know how much you put in. So what we're going to be doing is we're going to be looking at the Foley bag and seeing how much are we taking out of that Foley bag, but we need to subtract from that the amount of solution that we actually put in as we were doing the irrigation. So keep that in mind when you're doing your I&O calculations. Usually your patients will have this in for a few days, and once we see that the urine, okay, that starts to look more of a typical urine coloration, I'm not really needing as much irrigation, then they may just use it as a regular Foley until the patient is ready to have that removed completely. This is an image of the nephrostomy tube that I was talking about. Again, these are placed for a patient who has blockage of the ureter, allowing the kidney to continue functioning, to continue filtering and creating urine, but it's going to come out through these tubes now. Because what we don't want to have happen is that the increased pressure from an obstruction go back up to the kidney and cause damage to the kidneys. We don't want that kind of event to occur. So we can put these in, and the tubes are then going to continuously drain the urine directly from the kidney. Sometimes these are going to be placed from a person having a stone that caused the obstruction, but it could be tumors as well. So abdominal tumors that put pressure upward, really severe stricture. When I was working in OB, we saw these in patients that were multip patients. Sometimes they would have to put nephrostomy tubes in place for those patients because of the abdominal pressure that was occurring. It was potentially causing kidney damage. So they're placed externally. They go into the pelvis of the kidney. And as we do that, I'm going directly into the kidney. That means I'm a huge increase in the risk for infection. So pyelonephritis is a really big concern for these patients. And these tubes are not comfortable. So as long as they have to be in, they'll be in, but we don't want to use these as a long-term solution. The urine should always be flowing freely. It's critical with these that they're not kinked, twisted, clamped, anything like that. They always need to have outflow. So always look at this part of just your hourly assessment when you're in the patient's room. If you're on a regular floor, making sure that there is good flow and good output. Occasionally, if we're starting to see that the nephrostomy tube is not really draining well, they may order irrigation with a small amount of sterile saline. 5 ml is usually the absolute max we would put in, but you do have to have a healthcare provider order for that, so you can't just decide to do that on your own. These are some examples of different types of urinary diversions that we can have. We could have a stoma. A stoma is where they take a portion of the intestine. They're going to connect the ureters to that. They kind of isolate that piece of intestine and connect the ureters down. And the patient will wear a urostomy. So it's a bag on top of that stoma there that it's just going to always drain urine into that bag. That bag is always full. So they're constantly having to change it. It's really hard to do things. They really don't have much independence with it. So the stomas really are not going to be a long-term solution for patients because it's just a continuous drainage of urine into this external bag from that stoma. Sometimes my patients with bladder cancer, they will actually have to remove their bladder, so they will need to have some other type of diversion. And so they want something that's going to be allow a little bit more independent. And so they will use a pouch procedure. So a pouch procedure is where they create this ileal conduit. So we're taking a portion of the ileum, and I'm just kind of separating that out from the small intestine, and they form in surgery this little pouch. And then the ureters come down and they attach to the pouch. Now the pouch is going to have a stoma on it, but we use a special type of valve. Oftentimes they're variety of different types, but oftentimes they'll use kind of a nipple valve, which my patients like because it helps prevent with leaking. So what we do is we actually teach the patient now how to catheterize themselves using sterile technique into this pouch. And so they have a little bit more control. Now it's not innervated in the way that the bladder is, so they don't know that their pouch is full. They have to time it and say, okay, on a regular basis, I'm going to go in and I'm just going to catheterize this pouch. So that's another way that they can do it. Your patient can also have something called a NeoBladder or a new bladder, which is growing in popularity as a urinary diversion. So it's similar. The pouch is going to be made from the intestine, but it's going to be connected down to the urethra. So the patients can put pressure on their abdomen when they need to go to the bathroom. They're not going to have that sensation again because it's not innervated. So they have to tell themselves, okay, every few hours I've got to go in to do this. But they go in and they put manual pressure on their abdomen. It squeezes this new bladder, and then they're excreting urine through the urethra. So it's a little bit more like what they were doing before, a little bit more comfortable experience for going to the bathroom. But we do have to talk to them about making sure that, okay, I've got to make sure I'm evacuating this on a regular basis, and we need to make sure that urethra is fully functioning. We don't want any damage to have occurred in that urethra. Otherwise, this procedure will not work. So in Canvas, you have a worksheet that I want you to complete. So go ahead and pause the video here, and you want to go through and determine what care you would need to provide for a client who has each of these procedures done, and then bring that worksheet with you to class. All right, I hope you were able to get that worksheet completed. We're going to finish up this little section by talking about some additional men's health conditions. Now remember, STDs and STIs you're going to be doing in your maternal child portion of the course, so we're going to jump right into looking at ED here. But as you think about your STIs, your STDs, remember that we can't just treat one person. We've got to treat the partner, partners, pairs, whatever combination of sexual partners that the patient has. So we're going to talk about ED, or erectile dysfunction, which is fairly common in middle-aged men up to my older adult. If we see ED in a younger man, it's typically from alcohol or drugs or some type of substance abuse, or it could be a side effect from a medication that they're taking, or it could be more of a psychological element as opposed to a physical element. So assessment is really key. We have to be comfortable talking about this with our patients so that they feel comfortable sharing with us their concerns and what's going on. ED is a complication of some medications. It's also a complication of some different disease processes. So if somebody has a new onset of erectile dysfunction, we do need to encourage them to be fully evaluated, do a full workup to see what comorbidities might also be present. Because sometimes if we can get those comorbidities addressed and under control, the ED may resolve. Now, sometimes it comes from a vascular disease, so we're not getting sufficient blood flow to the area, and that tends to be the most common cause of ED, particularly in my middle-aged to older adult man. Typically, when they are doing a symptom analysis, they pay close attention to the timing of the onset of ED. So if it's more of a gradual onset, they've been noticing that they're having more and more trouble, that's getting progressive, typically that's related to something physiologic. If it occurred quite suddenly, all of a sudden this occurred, oftentimes that's associated with a psychologic issue. There's a variety of different types of tests that can be done. Again, they're also going to be testing for comorbidities as they make this diagnosis. The aim is really in collaborative care. We need to make sure that the patient as well as his partner or partners are having a really satisfying sexual relationship. And so a part of this really is looking at what can we do in the lifestyle? Are there things that could be altered? Sometimes it's looking at medications, but we have to, again, look at the comorbidities because a lot of these medications we have to be really, really careful with some other disease processes that they may have. We are going to end this section with just a brief review of health promotion practices. So something that is very important, in addition to my safe sex practices, making sure just overall we're having a healthy lifestyle, is that we are educating our young men to engage in testicular self-exams. This should start as soon as they hit puberty because testicular cancer tends to occur more in the younger adult. The best time to perform these exams is during a warm shower because the testes are going to hang lower, which makes it a little bit easier for the patient to palpate them. They should feel round and smooth, and one may be larger than the other, and that's okay. The size really isn't as important, but we are checking for different types of lumps. Additionally, you want the patient to pay attention to any pain or discomfort. The whole time they're performing the self-exam, it should be painless. And so if they have a lump and there's no pain there, that still needs to be evaluated because that could be indicative of testicular cancer. If they're having pain, but they don't feel any lumps, it could be technique. So perhaps the way they're doing the exam isn't appropriate, or they may have some other type of complication, such as an infectious or inflammatory process. So any pain or any lumps, both of those, whether they're together or not present together, must be evaluated. Again, because a painless lump or even heaviness of a feeling in that scrotum, a lot of swelling there, all of those things can be signs of testicular cancer. Now, if we capture testicular cancer early, they usually have a pretty good survival rate, but the way they've got to capture it is best through these self-exams early on. If a young adult is diagnosed with testicular cancer, it is important as a nurse that we facilitate and advocate for the patient a discussion on if they want to do some type of sperm recovery, if they want to have their own children or their own biological children as they get older. So that is an important discussion point that needs to happen early on, which is hard to have that discussion when you've just been diagnosed with cancer. Sometimes our minds are focused in a whole host of different ways when we get that diagnosis. And our patients may not be thinking about, 10 years from now, 20 years from now, I'd like to have a child. And so as nurses, it's our responsibility to make sure that we have facilitated the initiation of that discussion. So that wraps up this section, and I will see you in the next section as we go over some different renal diseases.